So we'll go through the case itself interactively, and after that we'll talk about what actually happened in the real life of this case and mistakes that I thought we could all learn about, and a little bit about the condition as well at the end. So imagine yourselves as the first person that will see this lady, which is an 81-year-old female. And she stated that during the evening before, she was watching television and reading her Kindle when she noticed that she had a momentarily visual blurring. She said it lasted for seconds at most, and it went away. So she didn't think about it. She thought she was tired. And then later that night, just before she went to sleep, she described that there is a little brown band that moved from the outside of her left eye in the vision to the center of her vision, like a block. That lasted for a little bit longer, about 45 seconds. And then later, she then had a smaller version of this, but a black band-like thing blocking her vision again for 1 minute. But then it was late, so she went back to sleep. She then said that, So at this point in time, we asked her a bit more about, what are the symptoms that she had apart from the vision problem. She said no, there was nothing at all. And she had no headaches with these events at all. In fact, this is her first time experiencing anything like this. In her past medical history, she said that she had cranial aneurysm before the last 15 to 20 years, which was only monitored. She never had any intervention for it. She said she did have some migraines in the past, and even in the recent few months, she had ocular migraines, but the symptoms were flashing lights, and it was definitely different from this episode last night. She also said that she had hypertension, for which she is on medication for, and high cholesterol, hypercholesterolemia, as well as hiatus hernia. She stated that her medication is as below: felodipine, ramipril, loperamide, and she has a few of allergies or drug sensitivity, really. So at this point in time, I would have asked the audience what bit of the drug history is important to this case. I'll leave 30 seconds in case anyone wants to interact. So in this case, I find it really important to find out about when did the felodipine started, or whether there is any or ramipril, because she said that she had renal impairment in her allergies to ramipril. And I found out that actually these medications has recently been restarted, signifying that her hypertension wasn't well controlled before, and also that she's not on statins, even though she said that she has hypercholesterolemia. She said that she's declined the statin in the community, and she's aiming for diet control at that time. In her family history, there was nothing significant, nothing similar to what she has experienced before. And in her social history, she's never smoked, never drank, and she does live with her husband. Of note, because of the pandemic, we talk about the husband, and turned out she is the main carer of her husband throughout the pandemic because of the dementia, and hence she felt that that's why she wasn't really taking care of herself, so her blood pressure got a little bit more uncontrolled, and her diet too. So what would we do next if we have seen her in the A&E? if we are the first person that's seen her in A&E. We'll go through the physical examination. The basic things such as the vital signs is very important. And then we'll examine neurologically. As the patient said that it happened the night before and it's only two episodes and it's very short, I didn't expect to see any abnormal neurological examination here. So the neurological examination at that point was actually normal. It was also important to check about the cause of the symptoms. So we need to investigate the cardiac. So examine the cardiac, and there is normal heart sounds. There is no carotid bruit as far as we can hear at the time, and the pulse was regular in rhythm. Then we proceed to investigations. Oh, the neurological examination also includes ophthalmology, such as fundoscopy, which is the basic thing that we could do, and that was normal as far as we can tell. Investigations-wise, what will we do? So we'll order a variety of tests, which is the baseline, which is full blood count, making sure there's nothing else going on there, coagulation, renal function, CRP, and ESR. ESR to rule out giant cell arthritis. Lipid profile is also important because she said she has hypercholesterolemia, and as well as thyroid function tests. And then we'll proceed to ECG to confirm that at that point in time she's still in sinus rhythm. We'll also go for a CT head to make sure that this is not is there any bleed? Is there any anything that is going on intracranially, especially given that she had cranial aneurysm. So at that time, what is the differential diagnosis? So there, we'll break it down into a few things. It's either ophthalmology cause, so is it something predominantly due to the eye, the structure of the eye, the function of the eye, or is this a vascular cause? Is it transient ischemic attack, such as Amauroxis Fugax in this case? I mean, she did complain of the migraines before, ocular migraines. Could this still be ocular migraine, but a different variant from what she usually experiences? So what's next? We have done our first assessments and baseline investigations with the CT head. So immediate management at this point in time, I think we should treat it as Amauroxis Fugax, as that is the most concerning factor. We didn't treat it as giant cell arthritis, as she doesn't have any headaches, and the temporal artery pulsation was felt and palpable, as well as the ESR being normal. Hence, we started the patient on aspirin with lansoprazole because of a history of hiatus hernia. And controlling the blood pressure, the hypertension is very important here, as it's one of the risk factors for TIAs, as well as the hypercholesterolemia. Other investigations that is pertinent, but wouldn't be the very first thing that we do, are carotid ultrasound, which in her case, it showed some hard and soft plaques in the right carotid bulb, but no hemodynamically significant stenosis noted, hence we didn't hear the carotid bruit. Although we had an ECG that states that she was in sinus rhythm at that time, we needed to have a cardiac tape to make sure that she wasn't going in and out of paroxysmal AF, and echocardiogram to make sure that the structurally she's of the cardiac structure will be all right, that there is no other cause of emboli from the heart. Ultimately, at the end, this patient would actually need a TIA clinic referral, as Amauroxis Fugax is part of the TIA process, and she already had it twice. Also, noting that the patient is a main carer, although she's 81 years old, she was driving, so we told the patient not to drive as well. So that's what we hope that the case should go. But what actually happened for this lady was that she presented on a Saturday. Very sensibly, because it was an eye symptoms, so she went to the optician to be advised on what to do. So she felt fine the next day, and optician rightly referred her urgently to the ophthalmologist in the hospital. She was then seen same day in ophthalmology, who's done the bloods including ESR and fundoscopy, and all the ocular investigation showed that there was nothing structurally wrong, hence referred her to A&E for query stroke. She was seen in A&E, CT was done, there was no stroke, and for some reason there must be a miscommunication there, because she was then referred to our unit for headache, which the patient was very mystified. She actually asked the people there that why was she being referred for headache, as she didn't have headaches. She was then seen on the same day, but it's in the evening by now, after all of that being done, for headache, and she was asked whether she would she would like to wait for CT angiogram and lumbar puncture to further investigate these headaches. However, because she has the husband who depends on her, and it's in the evening, she would rather go home and come back 4 days later for follow-up, and then to further discuss this, whether there's a need to do a lumbar puncture and a CT angiogram. She then returned 4 days later, and then that was when she actually, when I saw her, she said, I'm sorry, but can we go through this again, because I think there's a miscommunication. So we started from scratch and asked her the history and everything, and that's how we found out that actually she should have been treated as Amauroxis Fugax rather than another thing. Although, understandably, it was her cranial aneurysm that probably prompted people to think about CT angiogram and lumbar puncture. So going through Amauroxis Fugax for those who are not familiar with it. Amauroxis means dark, and Fugax just means fleeting, so transient loss of vision. It can happen in either one or both eyes. Does not have to be complete loss of vision. If it's one eye, it usually tells us that the problem is in the front, at the front of the optic chiasm. If it's both eyes, it's usually at the back, so any point at the back of the optic chiasm, on the optic chiasm and back. The duration will indicate will slightly indicate what the process of the problem is. So for papular edema, it happens in seconds. If it's a vascular event, it happens in minutes, 1 to 15 minutes. If it's migraine, it's 10 to 30 minutes. Yes, there's a little footnote there where I put, if the history is unclear, we just have to assume that either one eye or both eyes is possible. This lady was very sensible. She covered her eye and make sure that it was, she knows which eye it was affected. Specific description of the symptoms can tell us a little bit more as well. So mild blurring of sometimes people say that it's a bit of blurring, sometimes people say it's fogging, sometimes they say, oh no, it's complete darkness, I can't see anything. If there's positive visual phenomena such as photopsia or skin delusion, which is those lightning strikes vision, then it's probably signifying that it's more like migraine. If these features occurs at the straight away, at the maximum, at the onset, and it doesn't evolve at all, then it's probably seizure. But if it evolves, then it's usually migraine. Negative visual phenomena indicates retinal ischemia. Red visual field, so erythropsia, usually it means that there is a hemorrhage, and it's usually at the anterior chamber. If it changes according to the exposure to bright light, then it means it's probably to do with the vessels. So it's retinal claudication, giant cell arthritis, or retinal diseases. And if changes according to the position of neck or posture, you need to think about the carotids, because that's where the carotids, the anatomical position is, where there's vascular still phenomenon. Changes according to the position of the gaze, then probably orbital mass have to be thought about. The last bit about after exercise or shower, likely indicating demyelinating diseases or optic of the optic nerve, or problem with vasospasm. Other associated symptoms, is there any headaches? Is it painful or painless? So migraine, angle closure glaucoma, giant cell arteritis versus thromboembolic disease. Is there any paralysis of one side? Is this stroke? Is there any and whether it's, it will tell you whether it's anterior or posterior stroke, depending on symptoms as well, such as the retrobasilar symptoms such as vertigo, dysarthria, and double vision. We went through the risk factors with the patients when with the case already, but we can just go through it again. So risk factors for this are usually atherosclerotic disease, so old age, diabetes, hypertension, high cholesterol, any cardiac disease, which is why cardiac examination was very important too. If it's a young patient associated with rashes or previous history of miscarriage, we need to think about antiphospholipid syndrome. And if there was any family history of, again, young strokes, patients who have strokes at a young age, then you think about hereditary hypercoagulable disorder. Is there any family history or personal history of migraine? So underlying causes, usually, and also the main important thing that we don't want to miss is the stroke or TIA, and ocular diseases, so the eyes. And part of the thing is migraine is quite common too. But quite a lot of these cases are mixed. They may have migraine and some ocular disease, but actually currently it's due to transient ischemic attack. So there's quite a lot of them are mixed or unknown. Investigations, we have really gone through it again with the thing, but let's just make sure we've not missed anything else. Ophthalmology evaluation if it's not already done. Main basic bloods, ESR to rule out giant cell arteritis. CT brain to make sure there's no bleeds, no masses that you can see. ECG, we talk about PAF. Carotid ultrasounds, talking about carotid stenosis. Echocardiogram, cardiac tape. Oh, did I just, oh yeah, ECG and cardiac tape is, we know ECG is at that point, cardiac tape is for 72 hours or awake to make sure no paroxysmal AF. Echocardiogram for cardiac emboli. And MRI to make sure about the aneurysm. EEG if you suspect there's any possibility of seizure, certainly not in this case. And depending on the risk factors or the previous histories that you found, any hypercoagulable testing. In the end, we need to treat according to the cause. So for this lady, it was transient ischemic attack, so we need to treat the cardiovascular causes. But yeah, if it's ophthalmology, if you find a mass, then there will be ophthalmology and so on and so forth. And this concludes my presentation. I think my supervisor is here, Dr. Kawa is here as well. So if there's any question, just let us know. Or if you want to go through the slide again, let me know as well. Oh, hi, Dr. Kawa. If you have a question.
Hi, Swan. Thank you for a nice presentation, and good afternoon, everyone. Just a little bit of a few comments here. Obviously, it's a classical case of Amauroxis fugax, but I'm not really sure whether these patients should be actually followed up in a TIA clinic or obviously
Yeah.
And obviously looking at the carotids there, and the plugs that are there in the carotid suggest that there's some soft, plugs as well. And regardless of the severity of the stenosis, the small plugs, because of the softness of it, can actually pre-form some emboli causing this TIA. And obviously these patients require risk factors management and follow-up, I guess, from the TIA clinic, and further risk stratification to assess whether there is this the morphology of this deflux in the carotid artery. But that's just a brief comment on this case presentation. But yeah, it's a good presentation from you.
Thank you. Thank you. Yeah, the patient was actually followed up by TIA clinic, and they've arranged for the scan and for the investigations. So yeah. Any other comments, if anything? I guess not. Thank you very much for attending, and thank you very much, Dr. Cowell, for your help and feedback.
Thank you all.